Tēnā koutou. E hui tahi nei te whakarewa tia tēnei kaupapa whakahirahira. Nō reira, tēnā koutou. Ka inoi ahau te ki te mata tēnei hui. Whakatakata hau ki te uru, whakatakata hau ki te tonga, kia mā kina ki uta, kia mā taratara ki tai. E hiake ana te atukura, e teo, e huka, e hauhu, tihei mauri ora. Morena, I'm pleased to welcome you all to another network meeting in which we're going to understand better the needs of people with young onset dementia. So if I could turn over to you, Susan. Thank you.
Thank you, Teresa. Tēnā koutou, ko G te whānau, ko Susan toko ingoa, ko tēnei taku mihi ngā tangata whenua o te rohi nei, ka nui te mihi kia koutou, nō reira, tēnā koutou katoa. So just echoing Teresa, a very warm welcome to you all to this, our last network hui for 2024, but we're looking forward to bringing you more hui in the new year. So the fantastic response that we've had to this, I think, is a credit to the network about how much goodwill there is and enthusiasm for doing better for people who are living with young onset dementia mati wari wari. So we have a fab four, the Beatles of speakers for you today. And the first of our speakers is Dr. Brigid Ryan. And Brigid is a senior lecturer and researcher with the University of Auckland. And she's also the chair of YODAT, the Younger Onset Dementia Aotearoa Trust. And Brigid's going to take us through some of the things we all should know about younger onset dementia in Aotearoa, New Zealand. Thank you, Brigid.
Thanks, Susan. I'll just share my screen. Hopefully everybody can see that now. Wonderful. So thanks to everybody for joining today. I'll start with my mihi. Kia ora tātou. No airangi, no kōturangi, hoki uku tupuna. Engari, I tupu ake o I otipoti. Ke tapu ki makoto ahau I noho ana. Ko Brigid Ryan ahau. He kairanga hauroru ahau I waipapa tamataro. Nō reira tina koutou katoa. So as Susan said, I'm a neuroscientist at the University of Auckland, and my main research interest is young onset dementia, with a particular focus on frontotemporal dementia. As Susan also mentioned, I'm also involved with YODAT, the Younger Onset Dementia Aotearoa Trust, and we provide services and support for people living with young onset dementia in New Zealand, and I'll talk a bit more about them at the end of the talk. So this is what I'm going to cover today. I'm going to start by defining young onset dementia. I'm sure there are many young onset experts in the audience, but I'll start with that just so we're all on the same page. And then I'm going to summarise what we know about young onset dementia in New Zealand from research that I and many others have performed. And then I'm going to finish with an overview of the support that's currently available in New Zealand and a comment about the support that I hope will be available in future. So what is younger onset dementia? It's defined as dementia of any cause that has symptom onset before the age of 65. So even if someone isn't diagnosed until they're 67, as long as their symptoms started before they were 65, they meet the definition. Young onset dementia means the same thing as early onset dementia, which is sometimes used, but we prefer the term young onset because early onset can be confused with early stage dementia, which is of course a different thing. So in general, dementia is thought of as affecting older adults, and this makes sense because the risk of dementia does increase with age. But what's not often appreciated is that quite a large proportion of those living with dementia are actually under the age of 65, and people can be as young as in their 20s. So the most common causes of young onset dementia are Alzheimer's, frontotemporal dementia, and vascular dementia, and Lewy body dementia is probably in there as well. But together, these three diagnoses here, Alzheimer's, frontotemporal and vascular, still only account for between 50 and 75% of all cases. So what this means is that there are quite a few people who have more rare causes of dementia in this younger group. Although Alzheimer's disease is still the most common cause in this younger group, it's much less common than it is in the older group. So if we look at an older group of people with dementia, about 2/3 of them would have Alzheimer's disease, whereas in a younger group, in the younger cohort, only about 1/3 have Alzheimer's disease. So as I said, what this means is that quite a large proportion of people with young onset dementia have conditions that are caused by rarer diseases, and this can make diagnosis more difficult. Young onset dementia is also more likely to be genetic than later onset dementia, and this is because almost all genetic dementia presents before the age of 65. So when I say genetic here, I'm talking about dementia that is directly caused by a genetic mutation. So why does age matter? Well, although the cutoff of 65 is biologically arbitrary, we think it's important in a number of ways, which I'm sure many of you will be familiar with. So firstly, the retirement age in many countries, including New Zealand, of course, is 65, which means that the majority of people with young onset dementia are working when they first notice symptoms. And in addition to work and financial responsibilities, many people have young children or teenagers. And there are also differences in the clinical profile. So, for example, young onset patients are likely to be less frail as a direct result of their age, and more active. And finally, it's also really important to note that many health systems, including our own, are organised by age, often with a cutoff of 65. And this can present challenges to people who are under 65 but need access to dementia care. And in New Zealand, we know that people sometimes fall between the aged care and disability care sector. So for these reasons, people with young onset dementia face unique challenges that are different to those of people who develop dementia when we're older. And so we think it's useful and necessary to consider these differences. And we know that the experience of New Zealanders with young onset is different to New Zealanders with later onset dementia because of some of the research that's already been done here. So a number of researchers have done this sort of research by talking to people who are living with young onset dementia and also their care partners. And this sort of research is summarised in this slide. So, for example, some of the sort of thoughts about it that people have had when this research has been done is illustrated here in this quotation. So this person has said, talking about her father with young onset dementia, the activities weren't to his satisfaction. I'd like to see somewhere for people who are a little bit more active. He's still fit enough to have a life. Why take it away from him? And this was particularly talking about someone who was in respite care. And this is a common opinion that we hear from people, that the services are just not age appropriate. And this work from Alzheimer's New Zealand in a qualitative report that they did in 2019, where they interviewed 11 people with young onset dementia. What they found is summarised in this quote, that younger people with dementia want services tailored for their age group. So collectively, this type of work, talking to people, has really illustrated the importance of and the desire for age-appropriate services in New Zealand. So in terms of how people are affected in Aotearoa by young onset, we have also done some work which was slightly different, where we've looked at a larger number of people, and we've used routinely collected medical data to compare the health and well-being of over 1,300 people with young onset dementia. And we compared these people to over 45,000 people with late onset dementia. And the point of this was to see if there are differences in the experience of people with young onset compared to late onset. And what these data demonstrated was that there are really important clinical and social differences between the younger population and the older group. And I've highlighted some of the important findings that we've found here. So, for example, we found that there was a higher prevalence of what we describe as neuropsychiatric symptoms and problematic behaviours in the younger group. So, neuropsychiatric symptoms are things like depression and anxiety, and problematic behaviours are things like being aggressive. And we also found that young onset patients were more likely to experience financial strain, which makes sense when we think about the age group that they fall into. When we looked at the care partners, we found that young onset care partners were more likely than older onset care partners to experience distress, anger or depression, and feel overwhelmed. So what this study does is it supports the conclusion that age does matter for New Zealanders with dementia. So our next question as researchers was how many New Zealanders are actually affected by young onset? And surprisingly, this question hadn't been answered before we did this work, which we published in 2022. So to do this, again, we utilised these routinely collected New Zealand data sets that capture almost all of our population. And they include anonymised data from New Zealanders, which relates to both clinical information and also demographic data. So we use these data sets to identify people who had a diagnosis of dementia and were under 65. And what we found was that there were about 3,500 people who we could identify from these data sets who had a diagnosis of young onset dementia. We were looking at data from 2016 to 2020, and we found that this prevalence or this number was really similar across these years. So in other words, if you take 10,000 New Zealanders who are aged between 30 and 64, you'd expect to find that 14 of those New Zealanders have been diagnosed with young onset dementia. And we found that this is quite similar to previously reported international data. And when we look at this data compared to the same data set when people are in the older age group, we found that this represents 7% of all cases of dementia in New Zealand. In terms of the actual age split, about a third of these people were between 60 and 64, and the majority are over 45. But there are still a number of people who are under 45 in this cohort. Ito is going to talk a lot more about how we can count the number of people in New Zealand and predict the number of people in New Zealand with young onset dementia after I've spoken. So this information in terms of how many people are affected is really important for healthcare delivery, obviously. We need to know the patient numbers so that we can plan for and provide appropriate support. And it's also really important to establish some baseline numbers so we can track if there are any changes in the prevalence over time. So as part of this work, we were also really interested in the ethnicity breakdown in this cohort of people with young onset. And as you can see here, Māori and Pacific were both overrepresented. So this graph shows the number of people in each ethnicity group, which are coloured in different colours. And you can see that Māori, who are represented by the purple bar, and Pacific people who are represented by the blue bar, both have a higher number than the Asian and European ethnicities. And these differences of 1.8 times and 1.5 times are actually even greater than the differences we see when we look at the older group with dementia. And so what this finding means is that we need dedicated and culturally appropriate resources, which won't be a surprise to anybody in the audience. So I mentioned that young onset dementia is caused by a number of different conditions. So what we hoped in this study as well is that using this data, we could find out a little bit about which particular conditions are causing young onset dementia in New Zealand. But unfortunately, what we found was that in many cases, the condition that actually caused dementia, so whether that was Alzheimer's dementia or frontotemporal dementia, for example, it wasn't actually recorded in the medical records. And so you can see that this big dark purple section here is people who didn't have a specific diagnosis recorded. They were just recorded as unspecified dementia, which is not very helpful for us. So this was quite disappointing that this data wasn't very helpful to answer this question of what conditions are actually causing dementia. And it means that we're not able to accurately report how many people have each subtype of young onset dementia in New Zealand. So it's also really important, as well as knowing the total number of people in Aotearoa who have dementia at any one point, it's also really important to know how many people are newly diagnosed each year so that we can provide support to them. And this is what we've done in this paper, which was led by Etu, and again published in 2022. So what we've done in this work is we looked through records from Waikato Hospital, plus a number of neurology clinics in the Waikato region. And we were able to, basically what we were trying to do is count all of the people who had a new diagnosis in the Waikato area over a 3-year period. And we were able to identify 64 new diagnoses in this period. So this was between 2015 and 2018. And if we extrapolate this number to the whole population, this suggests that when we look at Aotearoa as a whole, we would expect that 220 new diagnoses of young onset dementia are made each year. So again, this is helpful for us in terms of healthcare delivery and making sure we support these people. And again, this data suggested that there was a higher incidence in Māori compared to a non-Māori, which supported our previous work as well. So as I've already mentioned, diagnosis of young onset dementia can be more challenging than diagnosis at a younger age. And this is for a number of reasons, including that there are rarer subtypes. Dementia may not be suspected in younger people, and perhaps a lack of awareness among health professionals in some cases. We know that timely and kindly diagnosis is critical to patient and care partner well-being, even in the absence of available treatments. And so we've recently done some work to investigate young onset dementia diagnosis in New Zealand for the first time. And this is to find out whether this timely and kindly diagnosis is happening or not. This work was funded by Alzheimer's New Zealand, and Shruti Sharma is a wonderful student who's done a lot of work on this project. So what we did in this paper, or in this research, is we recruited people with young onset dementia and their care partners, and then we gathered information about their diagnostic experience using both questionnaires that were completed by the patient and their care partner, and also we accessed their medical records with permission. And what we were trying to understand is what's happening right throughout the process, from first suspecting something might be changing all the way up to actually getting a diagnosis of your dementia subtype. So I'd like to really acknowledge all of the participants who took part in the study from around New Zealand for generously sharing their stories. So what we found was that on average, it takes 3.6 years to get a diagnosis of young onset dementia in Aotearoa. So this is right from the point where someone suspects that something might be changing, all the way up to getting a diagnosis of general dementia. And this is very similar to the time that it takes in Australia that previous research has found out. And it's most likely longer than the time it takes for older people to get a diagnosis. We didn't look at that directly in this study, but previous work indicates that this time taken is longer in young onset compared to late onset when you do directly compare that. So when we asked care partners what they thought about this, 40% of them said that this was too long. And the feelings about this was summed up in this quotation when one of our participants said, the journey has been long and frustrating. So in terms of the pathway to diagnosis and what actually happens along this pathway, we found that there's a clear role for GPs in detection of suspected young onset dementia, because almost all patients present to their GP first. So when they think that there are issues, the first place that they go is to their GP. So that was 92% of all patients did that. So New Zealand guidelines recommend referral to a specialist for all suspected cases of young onset dementia. So this means that when someone presents to their GP, they should fairly quickly get referred on to a specialist. And we did see this happening most of the time. So in 50% of cases, GPs referred to a specialist within 3 months, which is great. But we did find that in a quarter of the cases, the GP didn't refer the patient for longer than a year. And we think this is an area that can be improved. It shouldn't take that long to get a referral to a specialist. All patients were ultimately diagnosed by a specialist, and this was a neurologist in 3/4 of the cases. So this work is under review at the moment and will hopefully be published soon. So the next step in this project, which we're currently undertaking, is to find out a bit more about the experiences that these patients and families are actually having. And to do this, we've conducted in-depth interviews with some people that were involved in this study so that we can get a better idea of what their experience has actually been like. And this work was funded by the Neurological Foundation, and it's been led by Dr. Ashley O'Mara-Baker. So Ashley has conducted 13 quite long interviews with care partners, patients, and also clinicians. And in this case, it's all of the people are from the Auckland region. And what I've done here is summarize the main takeaway messages which Ashley is finding from these interviews. So before diagnosis, there are often delays in presenting to the GP, which could be for a variety of different reasons. And people found that they were referred to multiple doctors before they found one that can help, which obviously slows down the whole process. They've found that there were discrepancies in outcomes and experiences depending on whether you're in the public or the private system. And people also found it hard to navigate issues around enduring power of attorney and advanced care planning. After diagnosis, so in this post-diagnostic phase, our interviewees reported that services and resources appropriate for young onset dementia were really hard to find. Including but not limited to day services, respite care, and also long-term care options. And they also reported that funding systems are rigid and difficult to understand. So with all of that background, what can I tell you about the support that actually is available in New Zealand? First of all, I just wanted to mention a little bit about YODET. So Young Onset Dementia Aotearoa Trust, which Susan's already mentioned I'm the chair of currently. This is a not-for-profit charity which was established in 2015, and our aim is to improve the well-being of New Zealanders with young onset dementia, their families and whānau. So what we do is we do provide some services and supports specifically for people with young onset. But we also work really closely with other providers. So we want to be really collaborative and share our expertise and anything we can to help other providers to provide services and support as well. So I'm happy to report that services and supports are becoming more available around New Zealand, although we've still got a lot more work to do. And these are things that are provided by YODET, but also by many other different providers, including the various dementia community organisations. So for example, we do have some day services which provide both activities for people living with dementia and also some respite for their care partners. And these are available in some areas across the country. We also provide some support groups. So there are various in-person support groups across the country, and YODET also provides some services, some support groups which are available to all New Zealanders because they're online via Zoom. And there is also some help provided by YODET and other providers to navigate the health system and identify financial support, particularly, which can be particularly difficult when you're in the younger group. So if you'd like more information about the supports that are available to you specifically in your region, I'd advise you to either contact your local dementia organisation or you can contact us directly at yodet.org.nz. And one of the things that we want to do, that YODET wants to do, is make sure that on our website we've got a good summary of the available resources and supports that are available. So if you can't find things in your own region, please get in contact with us and we'll see if we can find what's available. And on that note, if you know of, if you have a look at our website and have a look at our resources page and you know of other supports or services that we haven't listed or that we're not aware of, please do let us know. And I'd also like to make another little plug for YODET, which is to acknowledge that we currently lack Māori and Pacific representation on our board. So if you can help us with that, if you're interested or you know anybody who's interested, please do let us know. So I just wanted to end with my personal viewpoint about what support is actually needed. What work do we have to do? Where do we need to get to actually provide the required supports and services for people with young onset and dementia? So these are the things that I think are really important. Firstly, I think we need clear, easy to find information for people right from the beginning of the young onset journey. So we need help with navigating the health system. We need information about available services and support, and we need information about financial support, including really clear information about eligibility. And as well as this, we need just general information about what young onset dementia is, the diagnostic pathway, that sort of thing. And this is something that we hope that that YODET's website can help with in the long term. Secondly, as I've already mentioned, we need timely and kindly diagnosis for every New Zealander who's diagnosed with young onset dementia. And this includes this prompt referral from the GP to the specialist, which I've mentioned. I also think we need dedicated young onset dementia clinics across the country. I'm sure Darral and Erica will talk more about this. I think what's happening in Canterbury is a model that the rest of the country should follow. And we also need plans in place for post-diagnostic support right from that diagnostic meeting, so that people don't feel like they're given a diagnosis and then they don't have anywhere else to go. And finally, we need these tailored age-appropriate services and supports available across New Zealand. So at the moment, there are some parts of New Zealand where people have more availability of these sorts of things, but it's certainly not everywhere. So this includes respite care and day services, which include cognitive stimulation therapy that are obviously age appropriate, support groups, which are both in person and online, and finally specific tailored residential care for people with young onset dementia, which unfortunately is very limited currently. So thank you to all the collaborators that have been involved in this research. Special thanks to all those who've helped with participant recruitment. Most importantly, thanks to all of the participants themselves and the funders. And thanks to you all for listening. I'm very happy to take questions at the end.
Thank you very much, Brigid. Now, people can type questions in the chat and I'll pick them up. Or you can raise your hand and Bevan and I will try to see you. We do have one question that's come in, just checking in about the best number to use for prevalence. I'm going to hold that over till after we've heard from Etu, because Etu's going to be talking to us about some of the figures, and then I might get the two of you to respond to that together. We've got Gillian saying that it's so good to hear more about YODET. Thank you, Brigid, for letting people know about that and about the ever-growing website. I think one of the questions that we often does get raised in this network is around that thorny issue of aged residential care options. And Brigid, do you have any thoughts about what you have seen that is innovative and worth sharing, or where you see the major gaps that it's really important for us to be thinking about, first of all, for that aged residential care for people who are younger than most of the people going into residential care?
Yeah, absolutely. And this is something that we're actually getting quite regular, sort of almost weekly people contacting us through YODET now asking about this and saying, you know, I've got a family member who's under 65 and needs to go into residential care. Can you give us some advice about where to go? And unfortunately, we're not able to recommend any providers currently. We're not really aware of anywhere across the country that's actually providing that service. So it is, YODET is really interested in trying to do some work in this area currently. I think one of the issues with this as well is that many of the dementia organisations are quite obviously focused in people living in the community. And so that stage when you then get to living in residential care, there's not a lot of groups out there that are providing that support. So what we're trying to do is at YODET currently is put together a business plan for a small group home style model. And we think that is the best approach, but we've still got a lot of work to do around how that would actually work, and you know, we're certainly not experts in providing residential care. So if there's anybody out there that would like to help us with that, or would like to put us in touch with organisations that would like to partner to do that, then we'd be very happy to hear from you. But yeah, I think the short answer is we think that sort of small group community homes are the way to go.
Fantastic. And Winifred has just let us know that in Epsom there is a facility called Elizabeth Knox that's been supporting younger people with disabilities, and it might be worth contacting them.
Yes, thanks so much, Winifred, and that is one of the places that we do recommend. So thanks very much for pointing that out.
Yeah, and a similar question about from Gillian about the availability of respite care that is age appropriate.
Yeah, so I guess when I mentioned respite care, I was talking about the respite that a care partner gets when the person living with dementia goes to an activity group for, say, half a day. So that is available in some parts of the country. So, for example, Dementia Auckland runs a weekly session, and Wellington Yodet runs a twice weekly session. And Dementia Canterbury, obviously, which you'll hear about later, a similar sort of thing, and in other places across the country as well. So those sort of half-day respite options are becoming more prevalent across the country, but they certainly don't cover everywhere. But in terms of sort of longer term or overnight respite care, unfortunately, I think we have a similar issue that apart from the same respite care options that are available for older adults, I'm not aware of any places that have specific tailored young onset sort of overnight respite care options. So I think that's something that when I was talking about the sort of small group home, that's what we'd like to see, is that integrated into that sort of model as well.
I know that Darral will be sharing some thoughts later on as well. We have a question just coming through from Lou about do you feel that the current funding freeze on respite full-time residential care is or will be impacting on access that's needed?
I suppose it'll be impacting less in that there's not currently any specific young onset respite that's available, but certainly any reduced funding for respite care in general is not going to be good for targeted young onset respite care either. I'm certainly not an expert in what's happening in the sort of policy or government field. There's probably somebody else on the call who's will be better at answering that question.
Gillian's just chipped in to say that as well as the countries we're going to be hearing about from Darral, that community homes in Australia may be a bit further down the line than we are in terms of offering support for younger people, and there may be some really good models to check in from there as well.
Yeah, great, thank you. That's really good to know. We've had a little bit of conversation with some people in Australia, but yeah, we're sort of starting to see if we're starting off to see if there's any if there are any models that we can use in New Zealand, which won't be young onset dementia, but sort of related conditions. But certainly Australia is on our radar. So thank you.
Yeah. And Christina is just making a comment about the fact that down south, she's had a concern from a GP that they're referring to specialists but are having their referrals declined and being advised to follow the cognitive pathway. And that's quite difficult in the context of young onset dementia. And she's just wondering if that's something that you've heard feedback from elsewhere in the country.
Yeah, so the cognitive pathways at the moment are specific to the area that you're in. So I think, as far as I understand, they're still related to the old DHBs. So when I have tried to find the information in all of the cognitive pathways, it's actually quite difficult to access all of that if you're not a clinician. But what I do know is that some cognitive pathways are clearer than others. In terms of the New Zealand-wide guidelines that we have, I think the most comprehensive is the BPAC guideline, and that very clearly states that all people with suspected young onset dementia need to be referred to a specialist. So I personally think that we need to set a national consistent cognitive pathway that includes that advice. But yes, I think that is a problem that is inconsistent across the country.
Oh, thank you. Aotearoa is always passionate about therapeutic recreational specialists, And she's just checking in about whether they are part of the MDT approaches and support for young people living with dementia.
Not that I know of, but they certainly could be. Again, there's probably someone else out there who's better at answering that question than I am, but thank you for pointing that out.
And I was just wondering whether you might like to share about the online support group, because that's something that some people may not be aware of.
Yes, absolutely. So we have a number of different online support groups. So these are run by YODAT, but we've had some really significant funding support from Alzheimer's New Zealand to get these up and running. So we have two different categories. One category is a peer support group, and that's for people who are living with young onset dementia. So that's run by someone who does have young onset dementia themselves, and that's really a group where people can get together and talk about their experiences. The second category is for supporters of people with young onset. So what we have there is a number of different groups of different categories of people who are sort of dealing with different stages of supporting people with young onset dementia. So we found that it was really important to have groups available for people where their loved one was still living at home with them, but then a different group available to people who where their loved one has moved into residential care, because those two experiences can be quite different. And we also have a group that has been running on and off, which is available for people who are adult children of people with young onset dementia. So that's aimed at that sort of teenager up to sort of 30s sort of demographic. So for information about any of those, and all of those groups obviously are online, so they're available to anybody across the country, and we can also help with any tech support that you need. So for more information about any of those, please have a look at the YODAT website and you'll see all the contact details there.
Yeah. A very sober question from Virginia, who is just inquiring about the prognosis in terms of how long do people with young onset dementia typically live for after diagnosis, and is it shorter than people who get the diagnosis when they're over 65?
Yeah, that's a really hard question to answer because it varies so much based on the individual. So it does vary depending on the subtype, the type of dementia that people have. And it also depends on a number of other factors. So this is something that we hear a lot from care partners, is that they really would like to know some concrete information about prognosis for planning for the future, but it's really difficult to give that information. It's also quite difficult to determine whether people live longer or less long when they're diagnosed younger. And that's partly because if you're diagnosed later, then your life expectancy is obviously shorter anyway. It is often reported that people with young onset dementia have a more accelerated course, so they do live for less time than people with late onset, but I don't think there's actually strong research evidence for that. So I think in general, the sort of averages that you see of sort of around 10 years post-diagnosis seems to be similar between young onset and late onset.
Thank you. You're doing amazingly, fielding, just a whole range of questions. Perhaps one that we have got coming in is about the links with head injuries and whether that's something that's particularly relevant in the younger onset dementia area.
Yes, that's a great question. So I work very closely with Dr. Helen Murray, who is the sort of New Zealand expert on the neurodegenerative consequences of repeated head injury, along with a number of other researchers. So this is something that she's specifically looking into at the moment. And what we do know is that CTE, or chronic traumatic encephalopathy, or the neurodegenerative diagnosis that is associated with repeated head injury, that almost always affects people in that younger age group. So most people who are affected by that type of degeneration, which can cause this dementia, these people are in the young onset group. So we're certainly really interested in that category of people. Unfortunately, the data for New Zealand is really difficult to identify, and partly that's because of the issue that I mentioned, that the actual subtype of dementia is not always well reported. But also when we're looking at this repeated head injury group, it's even more complicated because we know that it's not necessarily a sort of a serious head injury like a concussion that might be recorded that is related to that dementia. In some cases, it's these much more minor repeated head injuries, which may not actually be recorded anywhere in your records. So, in summary, it's really difficult to get that data, but there are New Zealand researchers who are really interested in it, and it's currently something that's being looked into.
Yeah, and I'd just like to echo the compliments that are coming through, both for the work of YODAT and for just sharing so much knowledge that you're passing on with us today. We really appreciate it. So I'm going to turn to Itu now. And so Dr. Ituini Mau is a senior lecturer with University of Auckland and an old-aged psychiatrist in Waikato. So Itu is just such an effective advocate for raising awareness of the potential that we have to help to prevent dementia matiwari and the need for better services, particularly for our Pacific community. So Itu's going to come in and tell us a bit more about what we know about the patterns of young onset dementia in Aotearoa, New Zealand. So thank you, Itu.
Cool, thanks Susan, and kia ora koutou. Let me just share my screen. Right, is that coming through okay? Yeah, cool. All right, so I've just got 5 to 10 minutes to talk about basically the numbers, because I really like numbers. I probably should have been an accountant. And really with a focus on young onset dementia. Brigid's covered some of it already, but we'll just quickly go through some of the aspects, particularly, you know, focusing on how our population in New Zealand is quite diverse, and therefore there's going to be a shift in the next 20 years or so. So the first thing to say is that, you know, we know our population is aging. We know that we had the baby boomers, you know, born between 1946 and about 1964. That was a massive group of people, as you know, the soldiers came home and were welcomed back with open arms. And that population is, you know, was hitting retirement age from about 2011. So we've got this massive group of baby boomers coming through, and we're all living longer because people are generally healthier. So that means that in 2020, we thought there were about 70,000 people with dementia in Aotearoa. And of those, you know, as Brigid said, about 7,000 are under the age of 65. By 2040, you know, our population's growing by about 20%, but our number of people with dementia is actually doubling, because dementia is primarily a disease of older people. So as you get older, your risk increases. But what's really interesting is that we've got this baby boomer generation moving through retirement, but there's not that big population coming through after them. So actually, our number of people with young onset dementia is only going to grow by about 10%, to about 7,500 people. The second point is that, you know, it's really hard to get accurate numbers in New Zealand. So Brigid talked about, you know, the work that they did a couple of years ago, looking at all of the big health data sets that we have in New Zealand. And based on that data, we found about 3,500 people with dementia. We know the economic report, which is based on kind of more global data, but none of it New Zealand, suggests there's about 7,000 people with dementia, which is kind of the numbers we've quoted earlier. And so what we've done recently is we've done some modeling effectively with Brigid's data, and we've shown that if you account for the people with young onset dementia that aren't showing up in any of these big health data sets, the estimates in the economic report are about right. So we're probably sitting at about 7,000 people, you know, with young onset dementia currently. But it also means, based on that modeling, that potentially we're missing about half of all people with young onset dementia. So they're just not getting diagnosed, which is kind of what Brigid touched on. And she's also talked about incident cases of dementia. So my registrar, Dr. Fonseca, a few years ago, did that study in Waikato. And based on her estimates, we think that every year in New Zealand, we're going to have between about 250 and 300 people develop young onset dementia year on year. Now, this is where it gets really interesting. So we know that the age structure in New Zealand is very, very different. So the median age for the New Zealand population is about 40. The median age for particularly Pacific and Maori populations is a lot younger at about 23, 24. So what you can see on these graphs here is that Pacific people and Maori, the two graphs at the top, they taper really quickly as you get older. So we don't have that many Maori and Pacific people over the age of 65, but we've got a lot under the age of 65. Whereas you compare that to the European distribution in the bottom right there, which is almost a rectangle. So it suggests that, you know, there's a lot more older people in the European population. But because Maori and Pacific are younger, and actually Asian are quite young as well, that means we're going to have a shift in the demographic of people who have young onset dementia in the next 15 to 20 years. So the first point is that because Maori, Pacific, Asian populations are a lot younger, it means that if you look at, we'll take Maori as an example, if you look at everyone with dementia who are Maori, about 20% of them are going to be under 65. If you look at everyone with dementia in the Pacific population, again, it's about 18 to 20%, and similar for the Asian population. Whereas the European population on the far right there, because we're a much older population, means that actually only about 7 to 8% of all Pākehā with dementia in New Zealand are going to be under the age of 65. So that means when you're thinking about services and resource allocation, particularly for, you know, Maori, Pacific, Asian, non-Pākehā communities, we need to be thinking about the fact that actually 1 in 5 of people with dementia in those communities is going to be under 65, and they have very, very different needs to your classic, say, 75, 80-year-old who develops dementia. The second point that's really important is that because we talked about the baby boomer generation, because the baby boomer generation are now shifting toward retirement and there's kind of this vacuum left behind, what that means is that there's going to be a massive shift in the proportions of the different ethnic groups that have young onset dementia. In fact, what you can see here in the dark blue down the bottom is that in absolute numbers, Pākehā with young onset dementia are going to drop by about 10% because, you know, the population in the Pākehā in New Zealand aged between 30 and 64 is actually going to fall away. Whereas, you know, Maori, Pacific, Asian populations, because we're a lot younger, that kind of relative youth is now going to push through into the age groups where you will develop young onset dementia. So that's a really important figure to keep in mind, because what it means is that by 2040, about half of people with young onset dementia in Aotearoa are not going to be Pākehā. So we're going to end up with effectively a 50-50 split, which means that we're really going to have to think carefully about how we design services, how we allocate resources, what types of respite, what types of supports and services are going to be put in place to meet, you know, the very diverse needs of our young onset dementia population in the next 10 to 15 years. Brigid's already shown this graph. So all of the numbers that we've quoted earlier are really saying, based on aging alone, this is what numbers will look like. You know, Brigid's already shown that Maori and Pacific in the red and purple bars there have a much higher prevalence of dementia. And that's probably because the types of risk factors for dementia in those population groups are just that much higher. You know, we know that broadly speaking, the Lancet Commission has said 14 risk factors account for about 45% of dementia. We've done work in New Zealand a couple of years ago that shows that actually, because of the prevalence of risk factors, because of the burden of risk factors in our Pacific and Māori populations, the risk of dementia is higher, but it also means the prevention potential is higher. And most of that, and this is the work we're doing at the moment, most of that risk is probably due to social disadvantage. It's due to the fact that people who live in more deprived, more disadvantaged areas of New Zealand are at a higher risk. So this is work we just published earlier this year, basically showing that your chance of developing dementia effectively climbs when you move from more affluent areas to more disadvantaged areas. We've also shown that when you look at the prevention potential, people in kind of more affluent areas have a lower risk because they have lower burden of risk factors of developing dementia compared to people in the more deprived areas of New Zealand. And what's really interesting about this work is that it's saying it doesn't matter if you're Pākehā, if you're Māori, if you're European, if you're Asian. Pākehā people living in disadvantaged areas have the same risk as Māori and Pacific. Māori and Pacific living in the more affluent areas have the same lower risk as Pākehā. The risk is being driven by poverty and disadvantage. It's not being driven by anything inherently risky about being Māori or Pacific or any other ethnicity. And the reason that's important is because if you look at the distribution of particularly Māori and Pacific people and whether they live in areas that are affluent or whether they live in areas that are more deprived, what you can see there, again in the red and purple bars, is that Māori and Pacific populations really cluster around that kind of deprived area of New Zealand. In fact, we know that over half of Pacific people live in the two most deprived deciles of New Zealand society. So that's basically what it looks like. It says we know that dementia is associated with social disadvantage because social disadvantage means that you're more at risk of all of these particularly cardiovascular risk factors. We know that Māori and Pacific populations are much more heavily weighted towards areas of social disadvantage. And we know that the areas that they live in are really disadvantaged in terms of, you know, density of vape shops, density of alcohol outlets, density of fast food outlets. They are pushing the proverbial uphill as they try and navigate, you know, an entire kind of environment and community where they are faced with all of these things that increase their risk. I just wanted to end on this slide here, and it's basically saying that, you know, the dementia journey is a complex one. We know that, you know, Māori and Pacific in this case have a much higher risk of developing dementia and a much higher prevalence because of the risk factors. We know particularly for Pacific populations that the way they understand dementia, the way they conceptualize it potentially as an aging process rather than a neurodegenerative disease means that their understanding of the illness, the understanding of the need to seek help and support for it might not be as robust as people with, you know, perhaps more of an understanding and more of a health literacy around dementia. As a result of that, we know that for Māori and Pacific, about half of dementias go undiagnosed across the board. And even in those who get a diagnosis, we know that about half of Pacific people, for example, aren't getting diagnosed until they're at least at a moderate to severe stage of dementia. So that means two things. That means one, the burden of care is falling on their family and communities because generally speaking, you need a diagnosis in order to access support. And two, it also means that some of these interventions that might be useful, particularly in early stage dementia, things like the anti-dementia medications, things like cognitive stimulation therapy, just aren't as useful in people that have a more advanced dementia. And then finally, as Brigid's talked about already, you know, and particularly in the context of young onset, we know that the current services aren't fit for purpose. They're not really targeted at younger people with dementia, which means that even if people are deemed eligible, even if the funding's provided, their families and the people themselves with dementia might not see what's on offer as particularly useful. So the take-home message really is that actually in the next 20 years, the people with young onset dementia in Aotearoa will only, in inverted commas, increase by about 10%. But that masks the fact that, you know, the Pākehā population number will drop, but that Māori and Pacific and Asian populations in particular are going to skyrocket just based on their age structure. And that means that by 2040, half of dementias are going to be accounted for by a diversity of ethnic groups that are going to have their own needs and things that they expect from, you know, funded services. And then finally, which is most of the work that I do, you know, it's about understanding the fact that there is nothing inherently risky about being a certain ethnicity. This is all being driven by poverty and social disadvantage. Thank you.
Well, fantastic. We have a comment that come through from Sue just about what a wonderful and really useful presentation it has been, and really challenging about what we need to think about to make sure we have fit for purpose surfaces. So thank you so much. So I guess one of the things that Paul is just raising, he's saying, you know, it's not necessarily for today, but how can we get these messages out to make change? They're such important messages. And, you know, what can we be doing to raise awareness?
I mean, I think there's a couple of things we can do. So, you know, Budget 22 had the dementia initiatives, and we've got those 7 programs running. I have some involvement with the Pacific one up in Auckland. Initially, our proposal was really about post-diagnostic supports. What can we put in place for people that have a diagnosis of dementia? But then what we found very quickly was that it's almost pointless focusing on what supports you can provide to people with dementia if they're not even coming through the door in the first place. So we've had to pivot quite quickly, and we've kind of gone upstream a bit more. We run community workshops. We have a weekly radio program on the Pacific Media Network. It goes out on Facebook as well. And really, as that commenter said, it's about pushing the awareness, trying to increase that health literacy, because I think only then will you get people starting to come through the door. I think our system in general is pretty complex and hard to navigate. So things like health improvement practitioners, navigators will be important. And then I think on a more societal level, I think we need to be moving away from individual blame, individual approaches to risk factor reduction, more about the population and how we can change society, change living environments that people are in their communities to actually make healthy living an easier thing to achieve.
That's really helpful, thank you. And you know, Teresa, that's obviously something that the leadership and advisory group has such a wonderful opportunity for us as a community, that we do have that voice to be really taking those messages out to people who need to hear it. So we have a question from Steve, and again, this is around those risk factors, but just wondering about the role of alcohol in young onset dementia in particular, but, you know, dementia generally.
Yeah, thanks, Steve. Look, the thing about risk factors is that while dementia is primarily seen as a disease of older people, what we know is that the changes that start occurring in your brain probably start 15 to 20 years earlier, kind of in your 30s and 40s. And it's an accumulation of slow damage over time. It's an accumulation of kind of insults to the brain over a long period of time that gradually build up and result in the cognitive symptoms that you experience. So that's why cardiovascular health is so important. That's why things like alcohol are important.
Fantastic. Yeah, people just really responding to how important it is to get these messages out. lovely compliments for you, Etu. So, we have a comment from Manoa saying, we have a small project with Te Aotearoa in Wellington to establish enduring powers of attorney for Māori and Pacifica. And she's just putting it out there that EPAs, you know, when you're talking about disadvantage, that they're currently unaffordable.
No, I completely agree. Enduring powers of attorney are expensive. I know the public trust will do them if you have a gold card, but that kind of excludes people under 65. And even then you pay a small amount. I know particularly in Waikato, there's a couple of trusts that have started to be set up to look at helping people get these things set up. Yes, they're expensive. I'd really push people to think about them though, because the cost of a welfare guardian application and going through the court process, if you don't have an enduring power of attorney in place, is a lot more complex and a lot more expensive.
Oh, well, thank you so much, Etu. You really raised a lot of awareness, I think, and a challenge for us as a community to just do all we can to get those messages out. So our next speaker is Darral Campbell, and Darral is the manager for Dementia Canterbury. And as a Cantabrian, I can hand on heart just say that she is a regional treasure, just such an enormously effective, passionate visionary for really being on the forefront of what's being offered. But today, Darral is actually going to be talking about her insights from an opportunity to head overseas to see what's happening in other countries and what that might tell us about what best practice services might look like for people living with younger onset dementia wari. So thank you, Darral.
Oh, thank you, Susan. Tēnā koutou katoa. Ko Darral Campbell, tōku ingoa. Hello, everybody. I'm Darral from Dementia Canterbury, and it's my pleasure to share with you a report that's taken a while to come about. In 2020, I was a lucky recipient of a Winston Churchill Fellowship to look at younger onset services in Europe. But it took till 2023 due to COVID to be able to actually go. And this year, the report was finally completed and presented. So that's what I'm going to share with you. It was an invaluable experience, and it came back having me even more inspired about what things could look like. And sometimes when the going gets tough, it's great to actually come back and have some ideas about things that you do see working and working well. So, with in Aotearoa, with over 5 million people, we've really struggled to develop quality, accessible services for people living with young onset dementia. It's really important to talk about the population and the split in population between the north and the south, because that obviously impacts on services and accessibility. And that lack of differential services for people who have younger onset. I mean, currently it's very difficult for those of us working in the dementia space to get any kind of funding that says younger onset people and their whānau have specific needs. It's if you've got dementia, you're all the same, and it simply isn't. One size does not fit all. And I guess, you know, we have to come out and say these things. Our health system doesn't seem to see younger onset dementia as a particular priority. We see it as a significant priority, and we want to highlight that and talk about that and start, you know, the conversations so that hopefully those working at government level start to take seriously the needs of younger onset people and people living with younger onset, I should say, and whānau. So the background to this is, as I've said, on average, these are international statistics. On average, for younger onset dementia, people see between 2 and 5 different consultants or experts before they get a diagnosis. Brigid talked and referenced some of this already. There are stats out there that say on average it takes 2.2 years to get a diagnosis for people aged over 65, but 4.4 years for people who are under 65. I think, Brigid, your stat was slightly less than that in Aotearoa, which is great. GPs often attribute symptoms in younger people to other things. So initially, they're not necessarily thinking that this could be younger onset dementia. And so it's relatively common for people to present to us saying, I was treated for anxiety or depression or menopause, but not that there was any thought to the fact that I might be experiencing younger onset dementia. There is that higher risk for inherited dementia or rarer dementias in younger onset. Whoops, what have I done here?
Go back.
Yeah, bear with me. No.
Yeah.
So our traditional models are designed for people who are older. They're not designed for people who are younger. And at the moment, it's a kind of situation where it's like ordering a pizza and saying, do you want anchovies or not? It's not part of the expected makeup of the service. It's an option, maybe, if you're lucky. And so that's not acceptable going forward. We have to make it that it's an integral part of service and that people should expect that it's available. And we need to think differently about what younger people want. And over again, the evidence is there. Holistic service, knowledge about dementia, family-centred. What does that mean? And how do we unpack that? Specialist programs definitely are shown to make a difference. Oops. We have inconsistent underfunded services in New Zealand with no best practice in place. And that variance is often felt particularly in our rural areas where access to services is even more piecemeal. Key organisations do try and fill the gaps. The wonderful work that Yodat's doing, Dementia Auckland, Dementia Wellington, lots of others in this space. International reviews highlight the significant gaps in post-diagnostic support for younger individuals. So there's international evidence supporting the lack of support across the board. You'll hear more about the Dementia Canterbury program as it's evolved. I wanted to share with you this great model. I don't know how many of you have heard about the Angela project model, but it's something that I used as part of the process of looking at how dementia younger onset services were constructed and delivered to help me focus on areas. This is a big piece of research that took place in the UK, particularly related to younger onset, and this is what came from it. It's a really good model. So the key questions I asked when I went to visit, and I went to Alzheimer's Canada, British Columbia, I went to Alzheimer's Scotland in Glasgow, and I went to the Netherlands and a dementia specific centre in Florence, which is just out of Den Haag, looking at their younger onset dementia services. I focused on how do you get your referrals and what's the diagnostic process? What's the range and extent of your services? How are your services accessible? And what are the specific services that you offer, community and residential? And then the all-important and quite difficult question around funding. how are services funded? So at a meso level, I was looking at integration, whether care was managed by specialists, whether it was consistent, whether it was age appropriate, whether it was holistic, whether it was responsive, and whether it was accessible. That really helped me understand the context of the country that I was visiting and the way in which their services were constructed. So all of the services I visited had services for families and clients that were unique to younger onset. What became evident visiting all of them was that there was research and there was practice evidence that specialist services needed to be distinct from mainstream, and that they needed to cater for people throughout the entire dementia journey, not be piecemeal. That if we were looking at best practice, it was really important not to think that services stopped and started when people got a diagnosis and then didn't get referred or didn't get support in the community or didn't get support when they accessed residential care or respite. Because the Angela report exists, it seems a wonderful opportunity to use it as a basis to develop a model of best practice for younger onset in Aotearoa, and it clearly needs development so that it has a tangata whenua and Pacifica lens, but it's a great basis, and it would be great to think that that's something that we could work on in some way as we move forward. The evidence supports the fact that there should be availability of specialist younger onset programs in all our major cities across New Zealand, that the populations exist for that to be real. That we need specialist and interdisciplinary staffing. That a lot of the research that came through, a lot of the feedback from people living with younger onset dementia and whānau is around having specialists in this area who understand younger onset dementia, who understand the realities of living with children, with teenagers, with the impact of a loss of work, financial issues, partner stress, that those are things that require a specialist knowledge base. So what would I be recommending? That our programs need to be designed to be adaptable to the changing needs of individuals throughout the dementia journey, including options for respite that allow continued involvement in community-based programs. That's a big one, and in the examples that I'm going to give you shortly, I was inspired about how that could happen. The single site model, where everything is in one place, is a wonderful model, and I'll show you it shortly. But replicating this in New Zealand in the current climate is potentially quite challenging, where we've got all of our residential care sitting separate from our community care. And that's one of the silos that we have, which makes it difficult for people to come in and out of services in a way that might fit their needs. Doesn't mean to say that we shouldn't look at that and that we shouldn't think about how we could develop something working more closely together across the spectrum to work at all levels. The role of neurologists, I was interested, Brigid, in your stat around the number of people being diagnosed by a neurologist. Again, in all of the programs that I saw, it seemed to make a significant difference if the diagnosis was taking place in cognitive disorders clinics or environments by neurologists, and that was one less barrier for people. The notion of being referred to an aged care environment to get a diagnosis for some people was definitely a barrier. Oops, and that we need designated funding. I've done it again. So I wanted to show you the places I visited in the populations so that you could get a sense of what they're like. So Vancouver had a population similar to the whole of New Zealand. Glasgow, a population not dissimilar to a large city like Canterbury, say, in New Zealand. And Den Haag, a similar population to Canterbury. Sorry, I'm having some difficulty with my slides. So, the creme de la creme of models that I saw was absolutely the Netherlands. To say I was enamored is an understatement. I think we have much to learn from the way in which they've looked at developing their services. So they have interdisciplinary teams who are working exclusively in the young onset space, physio, OT, speech language therapy, social work, psychology, art, and music therapists, and medical professionals. And that the teams work with individuals as needed. They have a designated case manager, somebody who is engaged right from the get-go and is there throughout the journey, maintains regular contact with the person living with dementia, but also with whānau. And they have regular access to other team members for specialist assessments. So I visited the Mariho program and was able to spend some time in it. And it caters for people who are living in the community, who are needing to access respite, and then who are needing to go into care. And it caters for people all on one site, which I'll work you through. So it allows for respite services so that people living in the community can go and have one overnight stay, if that's going to work for them. Somebody can go in on a Friday night or a Sunday night and on the Monday morning wander downstairs to the program that they go to during the week, and they know everybody. The same team of people follow the person through the dementia journey. So the same social worker, the same physio would be involved with the person whilst they're living in the community and attending services, whilst when they enter respite and when they enter into a care, 24-hour care environment. At Florence, they had 2 floors dedicated to younger onset residential care. And the units were small, so they would have small units of 8 people living with younger onset, and they would have a much more home-like environment, so smaller lounges, kitchens where people could walk in and out and make a cup of tea or interact, spaces where families could do the same. And they meant that people, again, were not in environments that weren't unfamiliar. If they had been coming to the programs for some time, then they could still access some of those things. They could go downstairs to the cafeteria. They could go to a group if they felt like it. The residential care environments were very nice. I saw a couple of the rooms, and you might see a bit of a photo later. They were orientated to be definitely not hospital-like and not rest home-like, but to be home-like. So people had double beds, stereo systems, artworks, whatever they wanted, really. But they were small and they were inviting. And that they had a model of care planning and access so that the clients, as I said, could continue to access all of the services that they might have used initially day groups, cafe, gardens. They would have still a program at the gym if that's what they wanted. They would have still an opportunity to go to art therapy if that's what they wanted, or music therapy. They were still able to access everything that was in the building. It was a big positive that the people I met in the program talked about, that they had the same therapist throughout the dementia journey. That they didn't, as their dementia progressed, have another person coming in, so that they got to know and trust the interdisciplinary team, and the interdisciplinary team got to know them and their whānau very, very well. And that seemed a great leveller and a great opportunity to have consistency and trust throughout that journey as things got more difficult. This is a great, this is a photo taken in the cafe. And so that, of course, is a beautiful looking bookshelf, but it's in fact the doors going out, designed so that it doesn't appear to be a barrier for people. And it's not an invitation to be constantly leaving once you're inside. What's happening here? Whilst they didn't have a formalised education program, the staff had a regular get-together in the cafe where they ran a group that meant that in an informal way they provided education, and that group was open to everyone who might be using the facility, no matter which part of the facility you were using, or whether you were a whānau member or a care partner or a person living with younger onset. You could access those sessions. The social worker offered ongoing education and support, more individually tailored. Support groups were available for people, particularly around partners and around children, the individual needs of children. Groups were led by the psychologist who was involved, another discipline that was involved, and social worker. And there's the informal meetings in the cafe that I referenced. The ongoing support of the interdisciplinary team throughout the dementia journey. What happens, one of the questions I asked is, you know, if somebody goes into young onset dementia care, what happens as they age? And so there is a point at which, at around 70, they would then say to families, because the upper floor, it was, I think, 4 floors in this building. The upper floor had hospital level care. So if the person needed hospital level care, they could go to the upper floor if the family chose that, or they could move the person to another facility. But that always is a concern about moving people, which is why I was interested in how they managed it there. So what criteria do they use to access services? Based on individual needs. Available services included supported living, as all the way through to nursing home care. There's the at age 70 clients moving or transitioning. Service choices are influenced by the needs of the person with dementia and the family. These are the gardens at Marea Hove, and people were able to freely wander through the grounds, which people could garden if they wanted. They could pick flowers if they wanted. They could sit and picnic. They could do whatever they liked in the garden. It's a beautiful, peaceful space. So in one place, you have community support, you have respite care, you have sheltered living, you have nursing home care and hospital care all on one site. Similar services are available in the wider Amsterdam region. I only saw this one, but there are a number of others, which is really exciting. Where's it based? This was again really interesting. So Maria Hove is based in a mixed housing area amongst community shops and other services. So it felt like it was very much a part of the community. It didn't look like a hospital or a rest home. It looked like a community building. The cafe and garden are open to the community, and people can join the gardening group. How are services funded? So in the Netherlands, there's a mandatory insurance, and in many places, Canada had something similar around the mandatory insurance. I guess in New Zealand and Aotearoa, the only thing that's mandatory is ACC. And it does make you wonder about the uneven playing field that's created because we differentiate between injury and illness. If additional specialist or residential care is required, then there was some process to do a funding assessment. I didn't get to the detail of that. What they were very clear about is cost is not generally a barrier. There is income testing if financial situations change, but people are able to access services regardless. Funding increases with the level of care. And I want to share some client stories. So this lovely gentleman talked to me, and one of the first things he told me was that at one point he and his whānau were all set to come to New Zealand, and he'd heard all about it and had a lifetime wish that they had come, but in the end they didn't. So he was very keen to talk to somebody from New Zealand. So he was a man living in the community, and he was attending the younger-onset community program 3 times a week on average, but as he felt like. So he had some choice about whether he went or he didn't go. And I love that aspect. He got the train there, and he also had a bike which he was still riding, and sometimes he was able to ride his bike or chose to ride his bike as well. He was living at home with his wife, who was in full-time care at work, and with their dogs. And he talked about the reason that he came to the program because he felt very socially isolated, that he was at home by himself because his wife was working and because his friends were working. And that aside from walking the dogs, he didn't really have anything to do at home. And that he particularly enjoyed being with people his own age and the social connection. He told me he was involved in an individualised gym program, which he really enjoyed because he enjoyed fitness, and that he enjoyed the gardens. He was involved in the gardening group and the other groups on site. He loved having lunch and coffees in the cafe. He told me about the respite service, and I just thought this was so cool about how he and his wife could opt for him to have respite so that she could go away for a weekend or just have a night off. And that he was more than willing to go to respite because it wasn't in a place that he wasn't unfamiliar with. It was a place that he went to on average 3 times a week. And that he could still access the services if they were on when he was there. I thought it was a wonderful creative use of respite that I'd just love to see developed in New Zealand, where we made respite more accessible and more around the needs of the person and the whānau. He said, if I wasn't coming here, I would just be sitting at home watching television, being nothing. He was something. I really enjoyed meeting him. The second man I talked to was living in supported care, and he had previously been coming to the community program. He'd attended most of the day services, and then he'd chosen to come into care. He shared his room with me. He's standing in the doorway of his room there, and he delighted in showing me through his bedsit type room, and took great pride in how he had set up his room to reflect him. He said that he'd had the same health professionals involved in his care, and he said, they know me. He started having periodic respite and then had a gradual move into the unit as things became more difficult for him at home. He continued to access the space within the complex and loved going into some of the groups in the day program and through the gardens with freedom. He could, there was no barrier for him being able to do that. So, in short, I acknowledge the Winston Churchill Scholarship and thank them for that opportunity to travel. There were things about all of the programs that were positive, but neither Scotland or Canada has anything like the programs that have been evolving clearly for quite some time in the Netherlands. It provided great, rich fodder for me to bring back and think about in terms of the way we need to keep our service here at Dementia Canterbury dynamic and developing, and how we could start to think about what we develop in Aotearoa to meet the needs of people living with younger onset dementia. Thank you.
Thank you so much, Darral. Well, needless to say, you've converted us. So comments just about how wonderful that model is. And the dreaded question, do you have an idea about what it would take to get that onto the ground in New Zealand?
I guess the first thing is a recognition that younger onset is a specialist niche area and that funding needs to reflect that. And the second is, I guess, to emulate a model like the Netherlands has requires us to think differently about the way in which we're delivering services, so that we're working much more in partnership between community and residential care, respite care, and that's possible. It's just not how we've been doing it. So I think where there's a will.
Oh, thank you so much. Now I'm going to turn to Erica now, but I know that you'll still be there and we might be able to do some more questions jointly after Erica's presentation. So our last speaker for the day is Erica Collingwood, who is a wonderful key support worker. She lives and breathes young onset dementia, really, and she is just so passionate. And she's going to be sharing some of the initiatives that she's involved in down in Canterbury. Again, another little dose of inspiration for us all. So thank you, Erica.
Sure, thank you, Sue. Yes, my name's Erica Collingwood. I'm the younger onset dementia advisor at Dementia Canterbury. Kia ora toto. I'm going to talk this morning about supporting people living with a younger onset dementia diagnosis and their whānau in the community. Dementia Canterbury exists to support people and their whānau to continue to live fulfilling lives following the Mati Wareware dementia diagnosis. Our team provides free, community-based and specialised support services across Canterbury and the West Coast regions, and we're a long-standing not-for-profit organisation supported by the community. In 2022, we moved into our purpose-built Braintree building, the Braintree. My background is in speech and language therapy, and my present is in walking alongside people given a diagnosis of younger onset dementia under the age of 65 years. And these people, they've come from vibrant, contributing and connected lives into a space of many unknowns following a diagnosis. They never saw it coming, and a diagnosis that few understand in the setting of this age group. So what are those unique challenges of living with a diagnosis of younger onset dementia? We've spoken a bit about that this morning already, but universally there is a sense of loss and change associated with this diagnosis, leading to negative emotions, stress, social isolation and uncertainty. For clients, this can mean changes in self-esteem and a sense of self, a loss of purpose and value, a loss of connectedness, and a gap in age-appropriate services, as we've noted, can exacerbate all of these. For whānau, often a diagnosis can be long and a stressful time, and a diagnosis can also include dementias that involve personality changes, and we know this can lead to relationship strain. Care partners are often juggling their own jobs, reduced income, parenting children, and caring for ageing parents. Here is a clip from one of our carers.
It was a real shock because in January he's told he's got a mild cognitive impairment, which you can have for all your life, and then suddenly just a few months later he's been told that he's got probably Alzheimer's disease, and so of course I just kind of burst into tears because it was just such a shock. And then we had the whole process of, he was working 46 hours a week on a construction site. We thought, how did this happen? Basically, never ever thought that it would ever happen.
Research. The Angela report from the UK has been an important influence on thinking. Been the largest study of younger onset clients to date and aligns with a lot of what Brigid's already told us today. Additionally, policy. The New Zealand Dementia Matiwariwari Action Plan provides a mandate for our services, and it states that post-diagnostic support for clients is critical to living their best possible lives. Cultural awareness. When supporting tangata whenua, clients have opportunity to engage with our Te Rapa Manaaki, Matiwariwari group, and our Māori CSP groups. And listening. Our younger onset program is informed by the lived experiences of people living with dementia and their supporters. Focus groups, surveys with caregivers, and a hui with tangata whenua all gave us ears to their voices. So what are the important components of that post-diagnostic support that we've learned from research? Firstly, that focus on living well. Providing information and support leads to managing issues that arise. Fostering social contact to offset social isolation and support to mitigate those negative emotions that we just listed. Also, provision of a multimodal program. And this includes access to a named community support person, personal and emotional support, including peer-to-peer, as well as cognitive stimulation and exercise. And addressing that independence and togetherness. When younger onset clients spend time together, it can lead to a sense of normality and independence. And when supporters spend time together, it can lead to frank sharing and support. How do we gather all this information into a creation of our younger onset program? Oh, I've missed a couple of slides, sorry. So when we listened, what did we hear that led to our key aims? Clients said, we want to be ourselves. We want to be connected. We want to stay positive, and we want to feel fulfilled. Here's a video clip of one of our clients.
Hi, I'm Mike, and I've got dementia for the last probably nearly 2 years. You know, you're alone a lot of the time, and it's hard to explain to someone what it's like. But, you know, everyone in the group understands, knowing that you're with other people who are in the same position and understanding it. Because really, you know, I'm sitting at home and it's me without anyone else who understands, really. You know, my wife has got some understanding, obviously, but she hasn't got dementia.
Erica, your mic.
Is that better?
Yep.
Great, thank you. So what did whānau tell us? They said we want to be confident in our caring with tailored information. We want to be connected. We need to find balance with time to recharge, and we need to trust that staff are person-centred. How do we gather all this information into the creation of our younger onset program? In response, we created a younger onset dementia advisor role, providing access to direct younger onset support for client and carer. This began attendance at the Cognitive Disorders Clinic at the Neurology Outpatients in Christchurch. And this was to streamline our service delivery from point of diagnosis. This has been so great because it's led to informed referral process and connection with client and family, and in turn led to a reduced stress and reduced post-diagnostic isolation. A tailored response, really.
One of the things at Dementia Canterbury, and particularly having a dedicated young onset dementia worker, so Erica, has been just incredibly valuable, that I can actually say to people that, look, Erica is, you know, from Dementia Canterbury, she'd love to get in touch with you in the next week or so to discuss what we've just been going through. And I think that is a really powerful thing to be able to give people, so they're not just walking out the door with, you know, what is often some pretty devastating news or confronting sort of news, and there is that sort of immediate follow-up. And also, obviously, with a different focus to the way that I'm bringing things. So that's been incredibly.
We know that psychosocial education can reduce stress and help supporters connect more with their role. Education provides knowledge and develops strategies to better understand changes in behaviour and personality. Also, practical timing for these education opportunities is important for younger onset populations. And so we've developed a regular lunch and learn session for carers on a Saturday from 10 to 1. The format is a 2-hour specialist workshop and presentation on relevant topics, such as communication changes, supporting grief and loss, managing carer stress, legal matters, navigating the system, all with the perspective of caring for younger onset family member or friend. Lunch is then served and providing further opportunity for discussion and processing information, connecting and networking, and of course support.
The lunch and learns have been really, really good for me. I mean, I'm a professional person, right? So I really enjoy having detailed information, and I like structured information. And the good thing about lunch and learn is that you get really capable people running through sort of PowerPoint presentations, but also bringing in their personal experience. And we've had nurses, we've had people that work within the system and that. And to me, you can actually explore it. I mean, you can look at a lot online through the web, but in actual fact, the face-to-face hearing from these people and then having a coffee afterwards or during the sessions and talking to others it's gold. It's really, really good.
My name is Ilona Warren, and I am a carer to my sister, who's 15 years younger than me. I find that each time we come, we're given so much information, and you know, and everybody's busy writing their notes and scribbling it all down. But often the real things come out in the questions, or when we sit in circles. I've learned some really interesting hints by sitting in a circle with other people.
Literature supports meaningful activity for people living with younger onset dementia to stay strong, connected and engaged. So our Tuesday Younger Onset group is a weekly peer group that meets for 3 to 4 hours on a rotational format. Week 1 of the month is our walk and talk, and this provides exercise, social connection and just being outdoors, which echoes normal activity. There's always a coffee stop at a cafe, and a trip together in the van adds to that social connection. Mind and Music at base in week 2 of the month is a longer cognitive stimulation program, including lunch. There's a focus on sparking memories and reliving experiences, while music helps strengthen a person's cultural identity. It is also a shared emotional experience, and that results sometimes in some impromptu dances and sing-alongs. Out and about, offsetting that social isolation and a drop in confidence to go somewhere new or alone, these sessions invite an expansion of world and social connection and another chance to feel normal. In Mind and Movement, we know regular movement supports cognitive health, and this 4th session of the month uses a combination of movement, music, and cognitive stimulation to positively support cognition.
I'm pretty confident anyway, but it gives me something to look forward to, and we do some great stuff. As you know, we go to different walks and we go to nice places and we have fun, and that to me is if you're feeling happy, who wouldn't want to come to it? And so yeah, I love it, and you're like part of the family.
Research shows that physical exercise can help maintain those functional abilities and, of course, psychological well-being. A structured exercise program can encourage and support engagement. Our 1-hour fortnightly Energize and Exercise group, run by a qualified exercise trainer, ensures a balance of aerobic, strength resistance, flexibility, and balance. And recent measures have actually shown an unexpected improvement beyond maintenance in these areas for clients attending over a period of months. Also, our monthly Younger Onset walking group for those with younger onset dementia is another opportunity for gentle exercise and socialisation.
The Braintree Wellness Centre includes a specialised gym for people with neurological conditions. We hold a fortnightly Energize and Exercise session there for clients with younger onset dementia mati wari, providing a tailored group exercise program in a fun and social environment.
Every 2 weeks I go to the younger onset gym group, really having an improvement in my balance and also clarity of my mind as well a wee bit. Just getting that exercise really makes a difference for me.
discomfort around a lack of awareness in the community can sometimes lead to embarrassment and reduced confidence in our social situation. And this can lead to social isolations and loneliness. Our fortnightly Younger Onset Cafe gives opportunities for younger onset people with dementia and their whānau to attend in an informal setting. This reinforces social connection and that sense of acceptance and normality. Our bi-monthly Saturday socials are for all clients, younger onset clients and their families, and include events such as garden tours, petanque, Air Force Museum tours, and other attractions. So for this person-centred program, what has their response been? Returning to those key aims that clients told us to be themselves, to be connected, to be positive, and to be fulfilled.
We have a lot of support, the opportunities to do things individually or as a group, and yes, no, very exciting. What's happening next?
So pleased that I met you guys and you encouraged me to do this, and that my daughter bullied me into doing it, because it's the best thing that's happened to me in a very long time.
So in my mind, it is a meeting of other people with a like condition, if you like, and we do really interesting stuff when we get together, and it's always happy and it's challenging.
Tuesdays are Sarah's special day. She loves Tuesdays.
And what about whānau? What have they said in their feedback? I love getting all this information, different ideas. I have lots to take away and think about. Another said, connecting with others in a similar situation and knowing others have similar stories is wonderful. And another family member said, I see more of Mum's old self than any other time in the week. So offering a place of connection, belonging, and purpose has made a real difference to our clients and their families impacted by this diagnosis of younger onset dementia. Allow me to finish with this final look at our program.
We want this to be a partnership where people walk alongside us and others living with younger onset dementia and their whānau in the community, that no one walks alone. Having a designated younger onset program is something that we'd like to see throughout the country. We appreciate that people who are younger have very different needs, and that the mainstream dementia services don't meet those needs, and they don't meet the needs of whānau. We want this to be about connection, and for the journey not to be one that people take alone, but in partnership with us and with other people living with younger onset dementia.
Thank you.
Oh, Erica and Darral, just thank you so much. You've blown people away. Aki says that you've just about brought her to tears. You should be so proud, and people are just like, well, okay, yes, we need this all through New Zealand. So one of the questions, again, those practical questions, is about how is this, as Zara says, amazing, inspiring work. How have you actually managed to get this off the ground? Where does your funding come from?
I might allow Darral to answer that question.
So I have to say, like most things in a not-for-profit, we didn't have any money, but we had a passion. And so we started without any funding. But what we did is get 2 years of funding to research what we were doing. And we got that from Rata. Thank you, Rata. And then we had the wonderful Susan G sitting there, who was our lead researcher, who helped us put that research together and publish that research, and that then allowed us to negotiate partial funding with Te Wharaora. But the reality of our current program is that less than a third of our younger onset program is funded by contract. The rest is provided from, as the rest of the not-for-profit sector do, from other sources, from donors, from philanthropic trusts, etc., etc. I guess, it's one of the challenges that we all face, that, sometimes you can't wait for the funding. You have to do something to get the funding. For us, that's worked in this instance, but the challenge is that once you start, how do you continue and how do you grow it? The demand is such now that, we've got over 140 people with younger onset dementia as part of our service, and we could run our program, many, many more times than we are currently doing, but we don't have the resource to do so.
There's so many comments coming through about how emotional people are. It is so special, the work that you're doing. And I think that, Erica, one of the things that you were saying that is so true is about how, and Etu mentioned this, about how supporters need to believe that this is a type of respite, if you want to call it that, but is going to benefit the person. And so that you've got that total faith that this is a time that the person's going to thrive in, and how different that feels for people, which is, you've got a waiting list rather than, people being doubtful about this kind of a respite opportunity. Yeah. And Erica, just one of the things before we just hand over to Teresa to bring us to a close, we saw a little snip there of Campbell, Le Huron, and it mentioned about how you're integrated into his practice. And I wondered if you would just like to explain that a little more to people, because that's another very special thing in terms of young onset dementia.
Sure, yeah. It's a great partnership, really. We had the opportunity to attend the Cognitive Disorders Clinic, and that clinic is a clinic specifically focused on diagnosis and support of clients under the age of 65 who are presenting with cognitive change. And so Campbell has invited me as the younger onset dementia advisor to come as often as I can, really, but presently it's once a month I attend the clinic there, and that's a 4-hour clinic where clients who've been referred from GP practices with neurological changes and cognitive change are then assessed by Campbell for what comes next, really, whether that's a younger onset dementia diagnosis or whether there's some other pathology behind the changes.
That's such a wonderful example of integration. Now, in the comments, because we just love this learning community, there have been lots of links and comments going backwards and forwards. And as always, we'll try to gather those up and share them. So that will include Darral's report, if that's all right, Darral. We'll put in a link to that. We'll put in some links to our other speakers and the information that they've been given, the Angela report, and some of the links to the YODAT and the available young onset dementia resources. We'll put in a specific link for the online support groups. People are very keen to Brigid to see how they can get involved in that. So we'll try to bundle up some information to go out and share that as we share the recording of this really, really wonderful session. So just a huge thank you to all our speakers for your time today, for your passion, for all that you bring to your work, and the gifts that you just give our community are huge, and we're so proud of you all. So would like to hand over to Teresa just to close our session.
Kia ora. Once again, we've had had a fantastic hui, lots of interesting information for us to disseminate. So at that note, I'd like to thank Susan and Shireen and Bevan for organising the network meeting and ensuring that we had a hui in which we learnt a lot, and I certainly did, so thank you. And so I've copied the hui. So kia whakairia te tapu, kia wātea ai te ara, kia turiki whakataha ai, kia turiki whakataha ai, haumie huie tā ikie.